We have really a wonderful group of speakers that I hope you'll enjoy what they have to say, and they're really all experts in their area that they're going to talk about. And my goal is to really start kind of basic so that it can set up some of the other speakers and speak to some of the more general issues about epidemiology. Where are we sort of with melanoma in 2013? Some issues in diagnosis, and prognosis, and some of the strategies to try to prevent melanomas as well. So this is almost the obligatory first slide for any melanoma talk or symposium. And the American Cancer Society basically every year predicts, if you will, they do this in January, they sort of predict how many cancers we're going to have in the United States, the various types of cancer. So it's called Cancer Statistics. And it's a freely available publication, and so we really see where we are with a given cancer. So for us, we're always looking to see what they're thinking and what they're saying in terms of melanoma this year compared with last year. And so you can see that here is melanoma of the skin. So it's broken down obviously by gender. So in men, here we have it, and in women here. So together, what we're looking at is over 76,000 cases of new cases, of primary melanoma are anticipated, in the year 2013. And this has been increasing, obviously, over the last 50 years. It's continued to increase. So it's something that we still have to do better about prevention, and I'll be talking about that. And again, the efforts to really address this in our children, I think, is where we're really going to make the dent over time to reduce, the number of cases and send me home earlier every day. And one of the, I think, important things is that when we look at, the number of deaths due to melanoma, it's not really in the top 10. So that's not to minimize the deaths that do happen, but again, it does, I think, tell an important positive story, which is that most cases of melanoma are not deadly, and most patients with melanoma do survive their melanoma. And again, it does point to the importance of early detection, because that really gives our best chance, both for the patient and for doctors to be able to take care of it. So it's good that we're not cracking the top 10 here, and this is not good, but at least the fact that we are sort of in the top 5, at least with men. And if you kind of jiggle the numbers a little bit overall in the population, it does help us get more attention, if you will, because of how prevalent melanoma is now in the US. So I'd like to start with, what are the risk factors? Again, many people here or their loved ones have already had melanoma, but I think that it is important to kind of go over this, and there may be some things, hopefully, that can be kind of relevant moving forward, even to people who've been diagnosed with melanoma. So what our skin looks like, our skin type and color, hair color, eye color. So people who are fair, have blonde hair, blue eyes, red hair, green eyes, all of these have been associated with an increased risk, of melanoma, and just being more susceptible to sunburn, obviously, is an important thing. But then also, history of typically more severe sunburns, especially blistering sunburns, can increase our risk later on for melanoma development. And of course, tanning bed usage. It took a long time to really get this data, but clearly using tanning beds is associated with melanoma. And again, reference to AIMS efforts to try to get rid of that, at least in the younger patient population. And then moles. If we have a lot of moles, that can increase our risk, even if they all look perfectly round and banal and symmetrical. But there's a gradient of risk such that even when we get to over 100 moles, that can increase our risk by about 10-fold. If the moles are abnormal looking, what we call atypical or dysplastic, that can also increase our risk. Even having one dysplastic mole, and I can tell you I've had one of those removed, can increase our risk, of melanoma. And congenital nevi that we're born with, this is a very controversial area. And small, sort of the small congenital nevi probably don't really have an increased risk. But there's some really giant ones that can have an increased risk. So our mole pattern is sort of a window into our risk factor for melanoma, and we definitely look at that. And then our history, our personal history of melanoma, if we've had one, we could have a second one, and so that's why we still need to continue to monitor the skin even though the melanoma has been removed. And then family history of melanoma, that also is a risk factor. So if there's somebody in our family that has had melanoma, it does put us at increased risk. We think that in about 5% of the cases that we see, that the melanoma can occur on a background of inherited susceptibility to the disease. So when we see it, sort of showing up with other melanomas in the family and also other cancers in the family. And so there are a couple of syndromes, what we call cancer family syndromes, that I wanted you to be aware of. There's one in which we see melanoma mostly with other melanomas in the family, and occasionally cancer of the pancreas. And so there was a gene identified some years ago called P16 that can be mutated. There's a difference in the sequence of this gene that can get passed down from one generation to another that can explain the susceptibility in that particular family. And then more recently, and I think this is really not as well understood and accepted really by the broader melanoma community, but certainly our own experience here has shown that patients, we see a lot, certainly in the Bay Area, of connection between melanoma and breast and ovarian cancer. And I'll be interested in Dr. Hamid's remarks about what he sees in LA area. But certainly, and we've done a lot of research in this area, and definitely some of the genes that are known to be involved in susceptibility to breast cancer and ovarian cancer, which are the BRCA2, which is more prominently known, but also one we've seen, can be associated with melanoma. And so we are actively screening for that in our population. And the reason why I think that's relevant is that if you do find through a melanoma group family a mutation, that can have serious impact in terms of what women can do to reduce their risk of some of these cancers. And also there's a lot of research going on to develop what are targeted therapies in the group of patients who have these mutations. So, and this is largely going on right now in breast and ovarian cancer. But if those therapies are successful, then the melanoma patients should also benefit from those sort of approaches, because the genetic underpinnings, what's really going on, the mutation that gave rise to the cancer, would be the same. So that's why we're actively looking at this area, because it could be actually not just of relevance to our family members, but also direct relevance to us if we needed it at some point from a therapeutic perspective. So you all know this, so I'm not going to spend a lot of time, but you got to talk about diagnosis and the ABCDs of melanoma. So A standing for asymmetry, B standing for border irregularity, C standing for color variation, D standing for diameter over 6 millimeters, although certainly this is an old concept from the 1980s and when they just had rolled this out. And so now, most dermatologists are not waiting for something to be 6 millimeters. If they see it looking irregular earlier, certainly they will be biopsying that. And evolution, history of change. If something is changing, certainly that also makes us think about that. But the problem with the ABCDs is twofold. One is that not every melanoma has read this textbook. And so melanomas can appear in ways, they don't listen to just because we have it on a slide, they're not going to listen to us. And so melanomas can appear, in different ways and not have read the ABCDs, not be dark. They can be red. They can look weird. They can look like a bump or a cyst or something like that. And so that can fool, even very experienced physicians. So, so that's one thing that, all of us need to be aware of. And then also, the ABCDs, as I'll talk about, with some dysplastic nevi, with some very atypical moles, they have read the ABCD. So not everything that has an ABCD, not every irregular mole is going to be a melanoma. So these are sort of just some basic guidelines, but you have to take a lot of other things into consideration: the patient, their skin type, the history of the lesion, what other history they have, and then common sense, which is not in the ABCDs. Okay, so again, like we said, melanoma can have many different faces, and this is an older classification, but I still think it's useful to kind of go over. The most common type of melanoma is what we call superficial spreading melanoma. I'm going to show you pictures later in the ensuing slide. So where we have this, usually a flat face is what we call the radial growth phase that may be going on. It's just kind of getting bigger but flat on the surface, pretty flush with the skin, usually for several years. And then eventually you get like a little bump there. And that is the so-called vertical growth phase, where it really starts kind of going deep into the skin. So again, we have a lot of times many years to intervene while a melanoma is still in this radial growth phase. A nodular melanoma, sort of by contrast or by definition, is a melanoma in which no radial growth was identified. So it really starts out as a new bump and direct growth into the skin. And those are the ones that really fool us, because they usually don't look like melanoma, and they start up as a new bump, and they really can happen kind of in between visits, and so they can, and this has been the one that's resisted screening efforts, because again, even if you screen somebody today, I may have one in a few months, potentially, that wasn't here today, and they can happen somewhat quickly. A lentigo-maligna melanoma is a type of melanoma that, again, it's usually slowly evolving on sun-damaged skin. This is a melanoma from chronic cumulative sun exposure, years of sun exposure, years of being out, beach, golfing, not wearing hats, and sunscreen. And what we're learning is that there are differences, not just in the biologic behavior and the clinical presentation of these, but also in the genetics. Sort of what mutations drive these can be somewhat different. And also, the fourth type is what we call acral, which means melanoma that is on non-sort of hair-bearing surfaces. So primarily, this is melanoma that can happen on the palms or the soles, and also melanoma that can happen sometimes in the fingernail area. So very, very rare types, but again, we do see these. So these are some pictures. So this is the superficial spreading melanoma. Again, somebody would have come up with a picture that this is a flat area for many years, maybe getting bigger and darker, and then eventually you could get this little, bump that develops. By contrast, again, a nodular melanoma doesn't necessarily read the ABCDs. It's pretty uniform in color, et cetera, but it's just a very different kind of pattern. And this is the lentigo-maligna that can kind of slowly get darker and bigger and on a sun-exposed surface, typically, the face, head, and neck, and in this case, the ear. And this is this other type of melanoma, the acral melanoma. So, we went from this kind of histological, something that they would, we could see it from clinical to people trying to describe these types of melanomas under the microscope, to then in 2005, a molecular classification scheme was described where, again, you can kind of, again, this is a superficial spreading, this is the lentigo-maligna. So they, it tried to sort, this is the on the foot, and this is melanoma actually inside the mouth, so a mucosal melanoma, okay? So this, we haven't really talked a lot about this so far. And basically they tried to sort of look at the extent of sun exposure. So again, we think that melanoma, the superficial spreading kind, comes from intermittent sun exposure, sort of, over time, and especially kind of an early, a more intense kind of exposure to melanoma. This is coming from chronic sun exposure. And then this, we think, is coming from very little sun exposure, although there is some evidence that even in these, where there's not a lot of sun, the UV does play an important role. And then here, there's no sun. And so what was satisfying about this model at the time was that you could take a look at these, you could sort of look at where it is, and then they start to define where the mutations were going to be. And you could say, if it's a melanoma here, this is probably going to be driven by this gene called BRAF that has become an important target for treatment. And if it's one of these other three ones, well, they don't have BRAF mutations, and they might have this other mutation in a gene called KIT, and that could be potentially therapeutically targeted. So it was very attractive and appealing, because you could maybe look at the spot and try to predict what's going to happen. Well, alas, nature is never that simple. And so it defied that, so what we learned as we did more research about it was that in fact wasn't really appropriate. And what we found actually is that with the melanomas that, like the lentigo-maligna type melanoma, the BRAF mutation is more common, than the mutations that the paper had said are more common in this area. Even in the acral melanomas, on the foot, palms and soles, BRAF mutation occurs just as commonly. So you can't really just look at the patient and say, they're going to have this. You really have to do the testing, and you can't do some kind of prediction. You really have to do the testing. So where we are now, in my view, in terms of melanoma classification, is that yes, we have these BRAF mutant-driven melanomas, and again, sometimes there's a little hyperbole in terms of how often they happen, but probably fairly, I think they do occur in about 40 to 50% of patients that we see, especially in the United States. And some people call them BRAFomas. It just means that it's a cancer that's driven by this BRAF. And then about half of them have loss of another gene that I think will become important over time, called P10. So that is just another part of their genetics. Then we have a second category of melanoma that has a mutation in a different gene in the same kind of family, in the same pathway as BRAF in the growth patterns in the cell, called NRAS. And that we see probably about 15%. And so recent work has identified targeted therapies that can work in this group. And our doctors are going to be talking about that later today. The third category is KIT. Unfortunately, despite the initial thoughts that it was prevalent in a much higher group of patients, we really only see it in about 1 to 2%. And certainly, I think as more research happens, other molecular drivers are being identified and will prove to be additional targets for treatment. So I wanted to talk about staging next. Staging is important for determining prognosis and treatment. So anybody who's my patient, we've already gone through that with the little form that we have and we give you at the end of the day, but especially the T classification. So this is for the primary tumor where the melanoma starts out on the skin. And we break it down into 4 different T stages, a T1 through 4. And again, this is both for you to know, but also to set up the other speakers after me. And so T1 melanoma, the first stage for an invasive melanoma, refers to melanoma that is up to and including 1 millimeter in thickness. And when we break down each of these T stages into T1A and T1B, on the basis of 2 other features, that if the feature is present, it makes it a little bit more of a higher risk and, rather than if it's absent. So in T1, we look at 2 features. One is called ulceration, where the epidermis, the top layer of the skin, is missing, overlying the melanoma. And again, this is something that the pathologist has to determine. So just because something could be bleeding or oozing or something like that, that suggests ulceration, but it doesn't prove it. It's something that the pathologist has to record. And then the other thing is what we call mitotic activity, which is just a sort of how many melanoma cells are dividing, in a given area, in a given millimeter squared of the area of melanoma at the time of the diagnosis. This is something that the pathologist can see, and so we've now started recording that. And that has also entered into the staging classification as of about almost 4 years ago. And then T2 melanomas, the difference is that they're thicker. So they're over 1 millimeter and they can go up to 2 millimeters. Here, we only have the ulceration being the sort of modifying factor. So A is without ulceration, B is with ulceration. And T3 is, again, the next thicker group, which is from 2 to 4 millimeters without ulceration and with ulceration. And T4 melanoma refers to those that are over 4 millimeters in thickness, again, A and B, without and with. Now, the next thing that we look at is the N classification. And this is a little bit complicated, so please don't try this at home. I am a professional, so this is very painful if you try to do it without a lot of memorization and training. So we're going to not go through all the nuances, but there are 3 sort of N groups. And primarily the thing to know is that they're driven by how many lymph nodes are actually involved. And that kind of makes sense intuitively, that if we have it in the lymph nodes, the more lymph nodes we have involved, the higher the risk might be. But that's actually what the data have shown. And the breakpoints for how many lymph nodes are 1 lymph node, 2 to 3 lymph nodes, and 4 or greater. So that's the initial kind of division, if you will. And then after that, as you know, You could potentially have what we call a sentinel lymph node identified, so a melanoma that's sort of microscopically in a lymph node that we could never feel. And Dr. Leon's going to talk about that extensively. And you can imagine versus a melanoma that, it's a lymph node that somebody could actually feel. And so again, intuitively that makes sense that if you have a melanoma that's microscopic, there are fewer cells there, and that might do a little bit better than a melanoma that is macroscopic, that you could feel. But again, that's what the research has shown. So we take not just the number of lymph nodes, but then also its character, and then basically divide it into these 3 different subcategories. There are some other areas that I'm not going to really get into so that I don't hurt myself or you. The next group is the M classification. This is where melanoma has spread beyond the lymph nodes and to like a distant organ or site, something like that. And so here we have 3 different breakpoints. M1A refers to melanoma that's involving basically soft tissue, but again at a distant site. So distant skin, subcutaneous, that's what subcu stands for, underneath the skin, or lymph node, metastases, or where it's involving in distant areas. M1B is kind of an intermediate group where it's involving the lungs. And then M1C is where there are any other internal organs beside the lungs. And the third group is we have this marker that many of you know of called LDH. And if the LDH is elevated, that is suggestive of a higher risk associated with melanoma once it's metastatic. Now, one word about LDH, it's the only blood marker we have, but it's a really terrible one. And so we do test it, in patients, occasionally if you're doing follow-up, we will test it. But LDH is very nonspecific. And so, if one of you has gone for, a marathon or even a 3-mile run the day before you did your blood test, your LDH will be elevated because there's muscle injury from just heavy exercise, and it'll spill LDH into the blood. So it's not really specific for melanoma. And so this is a challenge sometimes that it's not very good at detecting melanoma, that we can't detect otherwise. And so we have to use some common sense when we do get an abnormality. Also, medications can cause elevations in LDH, so we need to take that with a grain of salt. But if a patient has had metastatic melanoma, if we find melanoma in an internal organ, and that melanoma does have a higher LDH, that is clearly associated with a little bit more of an aggressive sort of pattern. So I think you have to think about the difference of what the LDH is really telling us. It's not as good a diagnostic marker, but better as a prognostic, a marker of aggressiveness if melanoma is present somewhere else. So I wanted to end in the next few minutes with some strategies for prevention and early detection of melanoma. So as a dermatologist, which is one of my primary roles, here are a number of things that I think are important and that what we do in our clinic. Sun protection, and we'll talk about each of these in some more detail. Clinical exams and skin checks, dermoscopy, and also mole mapping. Now, the first thing, I don't have a slide about this, but in terms of clinical exams, I always say to our patients that they're the first line of defense. So when we talk about skin checks, the first person is the patient, and we need you and your loved ones to be paying attention to your skin, because that's really critical. It's on your body, and also I can't tell you how many times, well, we know that patients have diagnosed their own melanomas very frequently, but also I can't tell you how many times that patients have said, I just had a sense about that one, and there was just something about it that wasn't right, and it may not look weird to us doctors. And so we need to hear that sense from you, because I think that I've certainly learned that that intuition is terribly important, and so you have to, again, you could look at something in a vacuum, but when you take into account the overall picture, then we'll all do better, and you will make us much better doctors, honestly, when we understand what's going on from your perspective that may not just show up on the way that a spot looks like. So in terms of sun protection, this is, has been an area of controversy for some time, but finally, about a year ago. We got data definitively that sunscreen use can reduce melanoma risk. And so thankfully it came from Australia. These studies would probably be very hard to do in the United States, and funding for them has really not been forthcoming. But in Australia they have the highest incidence of melanoma in the world. It's sort of what I refer to as nature's cruel experiment. You've taken the Celtic population, you've taken the English population, and you've put them in not in England, you've taken them out of there, and you've put them in Australia, where you have the strongest sun. And not surprisingly, you're going to get the highest risk, and specifically in an area of Australia called Queensland. And so what they did, so because they've had the highest, and they've been magnificent in Australia as a whole in public education efforts and sunscreen and just putting up trees, shade, so that especially in schools, so the children can play in the shade, given how hot it is and how much sun exposure there is. So they've really been have fantastic public efforts, given the burden that melanoma represents in Australia. And so what they did in this particular study was, in this area of Queensland, they took over 1,500 patients, and they randomly assigned them to daily versus discretionary use. So whatever the patient was going to do. Obviously, you couldn't give them a placebo because it's not ethical. But just sort of telling one group, we want you to use it daily. And they really monitored that. Patients had to bring back their tubes so they could see how much was used, how much wasn't used. And the sunscreen use was with this started out in the early 90s. So it was with a SPF of 16, and they were to apply it to the head and the arms, the group that did get assigned to the sunscreen use. And then so they followed this again. The paper came out last year, so this is 20 years later, and 10 years after the end of the trial, 11 new primary melanomas were detected in the daily sunscreen group versus 22 in the discretionary group. So that's half. That means there's a 50% risk reduction in the risk of developing melanoma. And then when they looked at, but this was both what we call in situ, non-invasive melanoma, as well as invasive melanoma. So when they looked only at invasive melanoma, there was an even greater reduction, 73% reduction, in the risk of melanoma. And also when they looked at the average thickness of the melanoma, when it was diagnosed, it was thinner, it was lower in the sunscreen group, again suggesting that even when you get a melanoma, using sunscreen may slow, its development and its progression. And if you think about it, this was, again, it was started in 1992. We didn't really have great sunscreens in 1992. So just from the SPF standpoint alone, we do much better, right? I mean, we could go to 50 or even higher. Broad spectrum sunscreens, UVA and UVB blocking, really not very effective at that time, not very much in vogue, in early 90s. And then patients were only supposed to apply it to the head and the arms. What happened to the rest of the body? So if you really took sunscreens that we had today, better sunscreens, more broad spectrum protection, really applying it to the whole body, I think we could have even a better risk reduction than this. But clearly, the data is in. It is in. We have this, and I think this is really important. And for the husbands, the reason your wives have been beating you up to do this, they have data to support it. And when you come and see me, of course, I support them as well to make sure you do it. So we have the data, and this is really, it is now very important. Now the issue with sunscreen, there are several issues with it, and that is that, it shouldn't, people miss it. Studies have shown that we don't use enough sunscreen. We miss it on some critical parts like the ear, the back of the ear, the temple area, back of the neck. So there are areas where people miss, so you have to be really careful about that. You have to reapply it, even though they say they're sort of, they're sort of waterproof or what have you. So we need to use enough of it, and also it's not a standalone thing. It's part of a much broader protection program where, again, wearing hats, protecting your eyes, and having protective clothing, those are key issues. So then in terms of other strategies for early diagnosis, and I'm just going to finish up in the next couple of minutes here, is again, patients who have a lot of moles, or we said that just having a lot of moles can put us at higher risk for melanoma. And so patients who have really many moles like this, it can be a real difficult task, both for the patient and for the doctor, in terms of figuring out, when do you take out the mole and which one's changing. And so, and it's hard for the patient to remember, and it's hard for the doctor to remember, was this one there? Was it really changing? What did it look like 6 months ago or 3 months ago? And so, one of the things that we offer is this mole mapping system. It's called Intellistudio, this is what it looks like. And basically, it's a stand with a digital camera that's hooked up to a proprietary software that this company called Camfield made that we use. And so what we do is nevus, which is a mole. We do mole nevus photography at baseline, and I'll show you pictures. And then the patients are followed, every 3, 6, or 12 months, depending, again, on their mole pattern and their own sort of history. And, we do a head-to-toe exam with dermoscopy. So you've all seen me kind of use this little handheld microscope, and, we kind of look at each of the moles individually, because that can help. That can improve our diagnostic accuracy compared to what just our eyes are telling us. And then on top of that, so as you know, we see the patient, and then we're looking at it with the scope, and then we can go back and compare with the photographs and really see what's going on. And so this monitoring can help to identify newer changing moles. So this is kind of what the software has done, and one of the things they've done is to basically split the body and the skin into all these different poses. And the idea is by taking these pictures in these different poses, you can kind of really capture more or less the whole skin in this particular situation. So our nurse, Leah, takes these pictures, and they're all done from the same distance, if you will. And then one of the nice capabilities about the software is that, again, you're taking the pictures at a certain distance, but then you can zoom in with the cursor on our laptop, and you can zoom in and you can see the individual moles. So here's the little cluster here, and you can zoom in on it, and even a little bit more you could zoom in, which I can't do here, and see that mole. So you can actually blow it up with fairly reasonable resolution, so you can really try to detect changes. And so this is actually a recent patient that we had who was coming in. We did the baseline exam at 5 months earlier. She came back for follow-up a few months later. And actually, she was the one. We had looked at everything. And we had looked at the pictures. Everything looked pretty good. And I'm almost out of the room. And she said, by the way, this is the last slide. She said, by the way, take a look at this. And so, there was this tiny thing here. And so we had to go back and look at all the pictures. And it was this one, this particular view captured that area. And we could see that actually it wasn't there. And then you kind of blow it up, and we saw this new one. And we could see that it actually wasn't there. And so, we'd had a discussion, had it removed. And it was very, very atypical, and so it's going to be totally removed. So anyway, these are the strategies that we can use to detect melanoma earlier, to follow it up. And I'm going to end there. So thank you for your attention.